Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of September 30th, 2024. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after a COVID and H5N1 update, I will talk about pregnancy, infants, COVID, and the vaccine. Taking a look first at SARS-CoV-2 in the wastewater, nationally, viral activity is still considered high overall and in each of the regions, with the exception of the Northeast, which is lower. It's considered moderate. All the other areas are high, but finally, all the regions seem to be heading down, which is very good news. And looking at the map, we can see that most of the country, again, is still in one of those two darker blue shades. So pretty much across almost all the northern half of the country, much of the northern half of the country is still high or very high. But we do seem to have some areas considered low, a few in the south like Texas, Alabama, and Georgia, as well as in the Northeast like Michigan and New Jersey. And New York is still coming in as minimal with 116 sites reporting. So I'd love to know what New York is doing to apparently keep SARS-CoV-2 circulation minimal. The West Coast is finally mostly moderate after being very high for quite some time now, most of the summer actually, although the state of Washington is still coming in at very high. And taking a look at emergency department visits, those continue to come down nicely. They peaked in mid-August, so a little over a month and a half ago, and they've been coming down nicely ever since. This data is through September 23rd, so a very updated, our most updated metric. And taking a look at deaths, unfortunately, those continue climbing, and these lag about a month behind. So the week ending August 31st, so far there have been 1,239 deaths recorded. And this is at least the fourth week in a row with over 1,000 deaths. We'll likely have that occurring for at least a couple more weeks, but then hoping to see things come down. We have every reason to think they'll come down because, as we've just seen, the wastewater is coming down, ER visits are coming down, as actually hospitalizations seem to be coming down as well. So we should be able to expect deaths to come down soon. We just don't know how long it will then be before everything starts to go back up again, but we'll just keep an eye on that. And some of that, of course, will depend upon the mutations and the variants, new variants. KP.3.1.1 continues increasing. It's now projected to be almost 60% of specimens. And as a reminder, those top two rows are the actual variant proportions. So those are showing the month of August, what they actually saw in terms of the specimens that were sequenced and the percentage in each variant. And then the bottom two rows are what is projected based upon specimens that they're seeing and the growth that seems to be happening. So those bottom two rows represent September, and these are forecasted variant proportions. If you look at the bottom two rows over to the left side, you can see that green color there, which is a really small sliver on the September 14th line, but you can see on the September 28th line that it is more than 3 times the size that it was. And indeed, that is the XEC variant, which I talked about last week. So it went from less than 2% to now 6%. So it's essentially tripled. And one thing that they note on the variant tracker is that when there's a lineage with a high growth rate, so it's growing fast, then there's more uncertainty. So there's kind of that disclaimer. And as I touched on last week, XEC is what's called a recombinant variant, which is basically when 2 strains of the virus get together and combine to form a new variant. And recombination seems to primarily happen when someone is chronically infected with more than one strain at the same time. So the recombination actually happens within the host or the person who is infected. So with the current rate that XEC, this latest recombinant virus or variant, it's still an Omicron subvariant, and it's not our first recombinant virus. But with the current rate that it seems to be spreading, it definitely could become the dominant strain over the next couple of few months. Or maybe we'll get another variant that emerges and outcompetes this one and takes over. And since we mostly seem to be choosing unmitigated spread, even in healthcare settings where we're more likely to see immunocompromised people, or we're more likely to see people with chronic SARS-CoV-2 infections, which means more likelihood of coming up with more recombination. So we're pretty much just waiting to hear the news about what SARS-CoV-2 is doing next. And it's not unusual for us to be monitoring these variants. It's just a little unusual for us to be having this much havoc, I guess, being wreaked all year round. With the flu, it's definitely the case that we watch the variants. There's just a lot of time and effort and expertise that goes into figuring out what influenza strain is going to be most predominant for the flu season and doing our best to develop a vaccine that will target the predicted strains. But with flu, I will now just call it a luxury that it is seasonal, whereas we know SARS-CoV-2 is not seasonal and is mutating in such a way that the new variants are basically causing problems all year long, much faster than we're developing new vaccines. So we need a better vaccine strategy. Until then, we're just more or less going to keep monitoring what's happening. And the vaccine that is out now, we have every reason to believe that it will provide protection against the currently circulating variants, including XEC. But of course, we'll be waiting for more definitive testing. We'll also be waiting to hear more clinically about what's going on with people who have this strain, if there's anything different or not. And so right now, we're just gathering more information, and we'll report more as we have it. And briefly on H5N1, unfortunately, not a whole lot seems to have changed fortunately, not a whole lot seems to have changed since I reported last week. I did review in some detail, kind of an overview of where we've been with H5N1 and where we are now. And I expressed a fair bit of frustration about how there seems to be at least the appearance of not enough urgency being given to the situation of this virus, which has pandemic potential, and just marching along from one species to the next. And the concern currently is that there's an individual who had not had any contact with cows or birds who was diagnosed with H5N1. And so we don't know where they got it from. And then subsequently, another 7 people or so ended up with flu-like symptoms. Most were healthcare workers, yet timely testing did not happen. So this is just pretty difficult to understand. It's definitely giving the impression that we're not concerned about whether there's human-to-human spread. And I just cannot imagine that this is actually the case. One thing I've touched on here before, I don't pretend to be an expert in this area, but I'm just going to talk about it again because it may be at the heart of what seems to be a less than robust response. And that is that we're having interesting new, maybe challenges with different agencies having jurisdiction over the different aspects of this outbreak. The USDA regulates meat and poultry and eggs and promotes US agriculture. And the FDA focuses on food and drug safety under Health and Human Services. And CDC focuses on human infection, but it doesn't have direct authority to test workers. There's no single unified food safety agency, and no federal agency has the authority to test for human diseases on farms and feedlots. So at this point in time, it seems that it's no one's specific job to contain the spread of H5N1. different agencies may have different pieces of it. I suppose if it begins spreading readily from human to human and creates a imminent pandemic threat, then the CDC can step in, I believe. But before that happens, in terms of monitoring, it seems we don't exactly have an active monitoring system for this or for any pandemic potential disease, despite all we've gone through with COVID. So I will note that the White House launched the Office of Pandemic Preparedness and Response Policy, OPPR, in July of 2023. It's in the Executive Office of the President. It's charged with coordinating and implementing activities related to pandemics or significant public health threats or disruptions in the United States. And this office took over the duties of the previous COVID response team and the MPOX team. And so I imagine, or I hope it's the case that the OPPR is busy working on all of this coordinating and developing across all these agencies. I haven't heard anything in the media about OPPR other than Donald Trump vowing to dismantle it if he's elected. It's also been reported that the Biden White House has requested $6.2 million to fund the office in fiscal year 2025. But other than that, despite what's brewing with H5N1, we really haven't heard anything directly from OPPR, let alone what's happening with SARS-CoV-2. But with H5N1 in particular, given all of the federal agencies involved, as I described, it really would be great to hear from OPPR, at least occasionally. Maybe they can do a press conference or get a Twitter account or something. Just if nothing else, than just to reassure us that these activities are being undertaken and that there is, in fact, coordination of these various agencies, because I don't think we really have a line of sight on that. So in the meantime, the guidance just remains the same. If you do get symptoms, flu-like symptoms, I think it is very prudent to go ahead and get to your doctor and get tested and have them to send it off for all the things. So flu A, flu B, COVID, etc. I think that would be a good course of action. But we're also going to avoid raw milk or raw milk products and make sure that our meats are thoroughly cooked and not touch dead birds or any wild animals. So to kind of recap so far, there's a lot of SARS-CoV-2 circulating around our environment. Does seem to be slowing down across the country in terms of wastewater and emergency department visits and also hospitalizations. Now we're waiting to see those deaths coming down before everything heads back up again, which is expected. Again, SARS-CoV-2 is not seasonal. It's still causing quite a lot of sickness, hospitalization, and disability all year round. And currently, it's responsible for over 1,000 deaths per week in the United States alone. And we're continually learning more about the impacts of repeat infection. None of it is good news so far. We will undoubtedly be discovering more about what happens when a person gets it multiple times, which is getting more difficult to avoid as fewer mitigations are in place. And it's a huge concern, especially for our children, who we would like to expect have many healthy years and decades ahead of them. But we just can't truly say yet what happens after 10 COVID infections, 15 COVID infections. We're still learning. And what happens when those infections begin at a very young age. And so that is what I want to talk about a little bit today. You may have seen these headlines over the past few days, and I'm so glad to see this information being widely shared, because frankly, I think we are failing in this department, and that is regarding pregnancy and early infancy. We've not been protecting pregnant individuals and newborns enough, and this is evidenced by the fact that both COVID and flu are in the top 10 causes of death of babies. And these are primarily vaccine preventable deaths. I reviewed this and the top causes of death among children in quite a lot of detail earlier this month. I linked that briefing in the post in case you want to check that out. That was just about deaths. This doesn't even count the hospitalizations. It doesn't count those ICU visits. doesn't count the mechanical ventilation. It doesn't count any lingering or post-COVID issues. We know that children are susceptible to long COVID, just like adults. We don't know what that looks like if you're an infant, but you certainly hate to think about repeated COVID infections throughout childhood, knowing what we know about post-infectious chronic diseases in general. And remember, I think we sometimes get a little desensitized to, oh, hospitalization, oh, ICU, oh, they didn't die. No, this can be quite traumatic. It can be quite life-altering, particularly any kind of ICU stay in the hospital, being on mechanical ventilation. And when that body is so tiny and those lungs are so tiny, this can be a setup for future respiratory issues, among others. And again, something we're still learning about. But what was being shared was some data that was just published last week, September 26th, in the Morbidity and Mortality Weekly Report. I linked it in the post. This report looked at infants under 6 months of age and the maternal vaccination status. So whether mom got the COVID vaccine while pregnant. This study was looking across 12 states in the United States from October 2022 to April 2024. So about a year and a half. And we know that everyone 6 months and up is eligible for and recommended to get the COVID vaccine. And babies under 6 months of age are not eligible to get the vaccine. So these babies are actually relying on antibodies they get from mom for protection. If they don't get antibodies from mom, they're not protected for the first 6 months of their life. So during that time, October 22 to April 24, there were 1,470 COVID-associated hospitalizations among babies under 6 months of age in this analysis. So that's actually quite a lot of hospitalizations, and these are babies. And as it relates to COVID hospitalization, the only age group with more hospitalizations than the under 6-month-old babies were the 75 and up adults. So, how we're always talking about, oh, or you always hear, oh, it's just the elderly that are at risk. Well, right after the 75 and up group, the next most hospitalized group is the 0 to 6 months old babies. So it turns out that hospitalization rates for babies under 6 months of age were pretty much on par with that of adults 65 to 74 years old. Another group that we're always talking about as being high risk because of being 65 and up. And as it turns out, our 6-month and under babies are essentially being hospitalized at comparable rates to 65 to 74-year-old adults. Also, this age group frequently experiences severe outcomes. So their little immune systems aren't developed yet, and without the benefit of those antibodies coming from mom during the pregnancy, this virus is still essentially novel to them. So it's potentially like 2020 all over again for each of these babies. So to speak to those severe outcomes, 1 in 5 of these babies that was hospitalized had to go to the ICU. Almost 1 in 20 needed mechanical ventilation, and 9 of these infants died during their hospitalization. And I'll mention here, they actually excluded the newborns who ended up with COVID on their newborn hospital stay. So this was only looking at the outcomes of those babies who contracted it after their initial newborn hospitalization. Something important to note, I've talked about this many times because we've seen this replicated, this finding replicated many times already. Only 24% of the infants had an underlying medical condition. And the most common of those underlying medical conditions was being born premature, which is not a very uncommon thing. But 76% of the babies who were hospitalized for COVID had no underlying condition. Yet they were hospitalized and even went to the ICU and even died without having had any underlying condition, 76% of the time. So this is a big deal because that's another thing we hear. Oh, it's just babies with underlying conditions. Well, first off, we have to be concerned about everyone with underlying conditions. A big portion of our population has underlying conditions, whether you know it or not, whether you think it or not, whether you acknowledge it or not. But when it comes to our babies 0 to 6 months old, we're seeing severe outcomes with no underlying conditions at all, 76% of the time. So this is obviously very concerning. And so these numbers, all these outcomes, the fact that they are second only to the 75 and up group in terms of hospitalization rates, these are obviously all concerning things. Now, when they looked at the maternal COVID vaccine status, what they found is that out of the babies who were hospitalized, 88% of them the moms did not have a documented COVID-19 vaccine during their pregnancy. 88%. And among the infants who died, 100% of them were born to mothers who did not have any record of COVID vaccine during pregnancy. So I think these data do speak for themselves. But let's briefly talk about mom. What about mom? There's actually quite a lot of data and information out there about the impact of COVID during pregnancy. It's quite concerning. It's quite disturbing. We're talking about two people essentially, and unfortunately, the outcomes can be very severe with COVID infection during pregnancy. And this has been established in all trimesters, across all trimesters, there can be severe outcomes. One of the challenges is that it's often the case with pregnant people, it's difficult to do many of the studies. There's a lot more to consider in terms of the ethics of doing the studies. It takes a lot of extra steps and effort, and rightfully so. And because of that, many of the studies on pregnant people are small, maybe a little bit harder to generalize than we may like. So I'm just going to briefly talk about a couple of studies I think are helpful. Both are linked in the post. First is a meta-analysis that ended up including 12 studies in 12 countries involving over 13,000 pregnant people. What they concluded here was that COVID infection increased the risk of maternal death and severe illness in both mom and baby. This meta-analysis did not find an increase in the risk of stillbirth. We know that some of the smaller studies have indicated that, but this is something that I think probably needs further study or bigger numbers. But there was a significant increase in the need for critical care for mom and or baby who got COVID. So during pregnancy. So it is well established that COVID causes issues in pregnancy. Pregnancy itself is actually one of the most significant risk factors for poor outcomes from COVID. We don't hear about this much because pregnancy is not an illness. It's not what we usually refer to as a comorbidity, but it is a state of being that we know clearly places one at increased risk of a bad outcome from SARS-CoV-2. And not only mom is at risk, but also baby. So we are wanting to avoid COVID infection. We know that COVID vaccine during pregnancy will significantly reduce the risk of getting COVID during pregnancy. And we know that those antibodies that mom makes in response to the vaccine will get to the baby. They will cross the placenta. So the vaccine itself doesn't cross the placenta, the antibodies, so the protection does. And that's what we want. That's what we need in order to protect our babies. And what about the COVID vaccine? Well, once again, there were a number of pregnant people in the original vaccine trials. A number of people became pregnant during the trials. Those individuals have been followed. There's been no safety signals. There's been no concerns. We've given millions of vaccines and not seen any signal or issue with them in pregnant women. But we know that all of this evidence and data maybe just hasn't been enough for everyone. People need more assurance. That is understandable, but we have it now. We have the data now, and there really is not anything that would indicate that we should not be vaccinating pregnant people. But I wanted to share this interesting analysis that was done in England, across all of England. And I think it's interesting because it looks at people vaccinated before pregnancy and then looks at their pregnancy later. because this is obviously one of the things that we've heard a lot of concern about. But this looks at 186,990 women vaccinated before pregnancy. So the study is kind of meant to help address concerns about future pregnancy after vaccination. So I like the study kind of directly answering this concern that has come up. I do think it's a genuine concern that has come up among a lot of people, understandably so, but has also been majorly exploited by peddlers of disinformation. And so now we're just having to address all of that. But this analysis looked countrywide in England at electronic health records. You all know I'm jealous that they have this. We don't have anything like this in the United States. But they looked countrywide at health records for all pregnancies reaching at least 24 weeks from May 2021 to October 2022, so close to a year and a half. And what they found is that compared to starting the pregnancy unvaccinated, receiving the COVID vaccine within a year before the pregnancy was associated with a lower risk of preterm birth and extremely preterm birth, and small for gestational age babies, so babies that were born tinier than we would expect for the time that they were in there, and also a lower risk of stillbirth in those moms receiving the mRNA vaccine. So not only did being vaccinated not increase the risk of any problems, it actually decreased the risk of adverse birth outcomes. So it is important to note that these favorable outcomes were really mostly focused on the mRNA vaccine, but they did also look at the adenovirus vector vaccine, which we don't have in the United States. But if you're from one of these other countries and that is of interest, the article is linked in the post. But clearly with the mRNA vaccines, being vaccinated decreased the risk of adverse birth outcomes, even with vaccines that were given up to a year before the pregnancy. So moms and babies do better when they don't get COVID. They do better when they've had the COVID vaccine. And it turns out that at this point, there really is no disagreement about this. So it's not just the World Health Organization and the CDC saying this. It's actually all the professional societies that look after our moms and babies, all essentially giving the same recommendation about COVID vaccine during pregnancy. So the American College of Obstetrics and of Obstetricians and Gynecologists, ACOG, very prominent society, Society for Maternal and Fetal Medicine, American Society for Reproductive Medicine, really important professional societies. They all essentially are on the same page and concur with the CDC and World Health Organization guidelines as well. And I can tell you that this is not always the case. Everybody doesn't always agree like this. There are areas where they don't agree, but this is one area where they do all agree. And that is because the data speaks for itself. So COVID is a leading cause of death among infants, including those without any underlying conditions. And it is a significant cause of maternal morbidity and mortality. And this is primarily vaccine preventable. So why would we not? Why would we not? So I think it's just really important that we all understand the vulnerability of our babies, the critical importance of protecting them from what really is a vaccine preventable hospitalization, vaccine preventable ICU stay, vaccine preventable death. So if there's a pregnant person or a young infant in your life that you care about, let's do what we can to make sure that they are protected. Couple of things I've heard, oh, my baby's only one, maybe I could just wait till they get a little older. And I hear this from parents who themselves are vaccinated. They're not against it. They understand the importance of it, but just emotionally, mentally, they're wanting to wait. And they have this notion that somehow waiting till they're older is better. It's not. It's not. The vulnerable time is actually at the younger age time. So we need to kind of get past the emotion and stick with the evidence. We also sometimes hear pregnant People who say they're afraid to take any medication or any vaccine during pregnancy. They don't want to do it unless it's absolutely, absolutely necessary. And again, on an emotional level, all of this makes sense. We want to protect our babies. We don't want to do anything extra. We don't want to do anything that might harm them. And that is why it's even more important to be critically evaluating everything. We have to get past that emotional reaction. It's okay to have an emotional reaction and a feeling about it, but then we got to take a deep breath. We got to sit down. We got to look at the evidence, and we got to do what's best for our own health and for our baby's health so that we don't have any regrets, that we don't have any of these terrible outcomes and say, oh my gosh, if only I had just gotten that vaccine. So once we've critically evaluated this issue, the choice is absolutely clear. It really couldn't be any more clear. The benefits of COVID vaccine far outweigh any risk. I think it's way past time that we just say that loud and clear. And I am talking to physicians. I am talking to nurses. I am talking to doulas. We don't get to just be tired of talking about something. We don't just get to be tired of dealing with COVID. We don't get to be tired of doing things that could save our patients' lives. There is nothing that should keep us from protecting our moms and babies from a terrible vaccine preventable outcome. And if you find yourself struggling with this, please reach out. Tell me what the issue is, and let's get past it. Because if you are in healthcare and you are not providing evidence-based recommendations, you are doing your patients a disservice. And we should be just as clear about this as we are about other things: smoking, wearing a seatbelt, controlling diabetes. This is not controversial. It was made political, it was made controversial, but it's not. And so it's really time to say this loud and clear so that we can prevent any further tragedies. So let's continue doing what we can to protect ourselves. As all of this science and information evolves, we're going to do the best we can with what we've got. The vaccination should be available pretty much everywhere: pharmacies, physician offices, etc. Get that updated 2024 vaccine. Wear a high quality filtration mask indoors. Gather outside whenever you can. It's almost always safer than inside. Still need to be careful, but much safer. Pay attention to your indoor air quality, improve ventilation and filtration. And don't forget to strategically test. We've got more free tests available from the federal government, and don't forget to order yours. Matter of fact, why don't you go ahead and do it right now before you forget? You can get 4 free COVID antigen tests for your household at covidtest.gov. And these are apparently good through the end of the year, but check your expiration date, see when it's updated too, and make sure you get a hold of this. It's an important resource. Should be free as much as we want, but at least get your 4. It's better than 0. And remember, if you do not have a primary care provider, please get one. Know how to reach them before you need them. Establish a relationship with them. Get your blood pressure checked, your baseline labs checked, and get the appropriate screenings for your age and risk factors. Know where you stand. And remember to eat a balanced diet, incorporate fresh foods, avoid sugary drinks and processed foods. Quit smoking, reduce alcohol, get some regular physical activity. Unless you don't feel well, in that case, please do get your rest. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. We will be taking next week off and then returning the following week. So we will see you then.